Hello to everyone. My name is Oswaldo Ortiz. I'm a fellow of Colon Cancer Research Group from the Hospital Clínic of Barcelona, and I would like to introduce to you our paper called Factors Associated with Complete Clip Closure After Endoscopic Mucosal Resection of Large Colorectal Polyps, recently accepted and published in Endoscopy. First, I would like to thank to all the co-investigators of the large clip group, especially Professor Heiko Paul, and to my mentor, Maria Pellicer. As all we know, endoscopic mucosal resection is the first-line therapy for large than 20 mm nonpedunculated colon polyps. Delayed bleeding is the most common adverse event following EMR of these lesions. Prophylactic clip closure of the mucosal defect reduces the incidence of this complication, especially in proximal polyps, as already demonstrated in the clip study. However, it is yet unclear what factors make it easier or more difficult to close a defect completely with clips. While it is expected that closure can be achieved after resection of smaller polyps, it is of interest to identify factors that are modifiable and may help to improve efficacy of complete clip closure. Therefore, the aim of our study was to evaluate factors associated with complete prophylactic clip closure of the mucosal defects after EMR of nonpedunculated polyps and to understand factors that are modifiable. This is an observational post-hoc analysis of the clip study that included 458 patients with 494 large polyps. Prophylactic complete clip closure of the defect were not possible for approximately one-third of these lesions. Factors associated with the complete closure in a just analysis were a smaller polyp size with an odds ratio of 1.06 for every millimeter decrease, those with serrated histology, and ease of mucosal lifting was complete. Aside from these non-modifiable factors, stable access and bloc resection were identified as the only modifiable ones. Analyzing one by one, we found that smaller lesions are easier to close, as seems obvious that it's more difficult to bring together two margins that are farther away from each other than two that are very close. Serrated lesions could be more frequently closed than those of adenomatous histology. One possible explanation for this surprising result is that serrated lesions may be less prone to submucosal fibrosis and seem to be loosely attached to deep structures, making the EMR procedure easier itself. Also, there are factors that can be changed and modified to improve clip closure. The first of these is accessibility. We found that easier access made closure more likely, which seems intuitive and is also in line with the finding of other trials. This observation highlights the importance of establishing a position which not only facilitates resection but also clip closure. Another interesting finding is the fact that the bloc resection was independently associated with complete closure of the defect. Although one would expect that this element is related to size, it appeared to stay as an independent factor in multivariable analysis in our study. Access and the ability to resect in bloc may vary. These factors cannot be easily modified. Endoscopy is typically strive to get into optimal position and to remove a lesion in one piece. Unfortunately, the study could not identify other modifiable procedure factors related or to facilitate clip closures, such as type of injection or use of cautery, etc. Technical aspects on clip closure can also influence these results. Although endoscopy's EMR volume was not associated with clip closure in our study, it is clear that clipping can be applied with a different skill level, and future studies may need it to determine a minimum skill level of this procedure. Overall, the study could not identify procedural factors that may be easily applied to improve clipping. These results highlight technical limitations and call for efforts that should focus on developing alternative techniques to close the mucosal defect and to prevent post-polypectomy bleeding. Thank you.